Welcome back, everyone, to the Coffee and Grace podcast with Amanda. I'm here with my personal friend and very special guest, Mrs. Rebecca Skillman. I'm really excited to have her on because I hope that this podcast will help you in creating your birth plan for a hospital birth. Rebecca has been a certified doula since 2022 and has attended over 100 labors. She homeschools and is a stay-at-home mom running a successful doula business, guiding moms through pregnancy and birth. And so I'm super excited to have you on today, Miss Rebecca. Thank you so much for being here.
Yes, thank you so much for inviting me on. And I definitely just hope that this can be a blessing to moms who are preparing hospital birth but want to know all of their options and really what's the best way to support, natural physiological birth in the hospital setting. Now, obviously, each state that you're in, the hospitals surrounding you, the labor and delivery wards are all different. So definitely know the hospital that wherever you're delivering. Just call them, say, hey, what do you offer here? What are your labor and delivery rooms like? You can do a tour of the rooms. I work 11 different hospitals, so I definitely see a wide range of practices, but sort of things I'm talking through might be kind of specific to my region. So definitely consult with a local doula in your area. They're very experienced in knowing what to expect when you're going into birth. So we have for you a birth preferences plan. Like this is just like an example to use as like a base template. This is kind of like how my birth plan would look if I were to be giving birth. And I have it broken down into stages. So this is to help everything be chronological. So when you're sharing it with your labor and delivery nurse, and I do recommend also making sure you have a conversation with, whoever's delivering your baby too. Don't wait until you're pushing out your baby or don't rely on your nurse to relay your birth plan to the doctor. So be sure to talk with them. And this way they can kind of zone into, okay, stage 2, these are her preferences, and things are kind of laid out in an organized manner. And these are all touching topics of things that basically, if you don't have a preference, then there's going to be something opposite happen. For example, we'll start off with stage 1. So I don't know if you have any questions to start, Amanda, before we get into going through these.
Nope, no questions yet. Thank you so much, though.
Okay,
This is
good.
going to be so helpful because this process is, I feel like, really overwhelming for a lot of women. So I
Right.
really
Yeah.
appreciate you taking the time to explain this to us. So yeah, I don't have any questions at this point. So take it
Okay.
away.
Yeah. Well, just speak up if it gets on. I'm sorry for the birds in the background. I heard them. Can't
That's
silence
okay.
it. So stage 1, when you get to triage, normally that's where you can go ahead and mention, hey, I want wireless monitoring because usually like the hospitals surrounding me have only a limited options for wireless monitoring. Like they might only have 2 systems and sometimes they're tied up. So them knowing that like ASAP, as soon as you get into triage, will help that to be ready for you. If they don't have the wireless option, then you can ask for the intermittent monitoring. Now, as a doula, I've kind of witnessed that the wireless is least invasive just because intermittent monitoring, that's where they're having to come in like every hour and they kind of disrupt your labor flow because they're trying to get a good, fetal strip of the baby for about 20 minutes and then leave you alone for 40 minutes. But then again, they're coming in every hour. And sometimes you'll have nurses that are intimidated by the intermittent monitoring and they kind of get frustrated with it. So if they know this ahead of time in triage, they'll kind of line you up with a nurse who they know is more skilled or more accommodating to like the wireless or the intermittent. Definitely limited cervical checks. I'm pretty sure most moms already have that. If you're already working on a birth plan, kind of goes without saying. Cervical checks really don't do you any good. They actually can cause harm, which we'll talk about a little bit later when we get to stage 2, as far as having someone tell you when to push or tell you where you're at in labor. And it's very subjective. You'll have one nurse tell you and I've had this happen at a birth where we had a nurse tell us she was complete. We got the delivery table rolled in. And then the charge nurse comes in and says, oh, you're only 6 centimeters. So you'll get different information that doesn't really benefit you and it just can disrupt your labor flow. And then again, can dangerously have you pushing too early. The next thing is please do not recommend pain relief options. Definitely know your options for the hospital you're going to. Like some hospitals will have nitrous oxide, for example. Um, you have IV opioids and then, of course, epidural. But to just have it in your birth plan where you don't want to be recommended anything just helps to not have that conversation too soon or be kind of pressured into that. Some old school nurses kind of want to get you on the epidural just so they can easily manage everything and not have to come in regularly to adjust your fetal monitoring. Next thing is no artificial rupture of membrane. So a lot of moms, myself included, we go into birth thinking that like our water is supposed to break. And so it's not a big deal if the doctor wants to break it. Just know that it really has a 40% C-section rate. The largest study we have on rupturing of membranes, they were trying to decide whether they should break your water at like 3 to 4 centimeters, so in early labor, or wait until more active labor, like 6 or 7 centimeters. They did find that breaking your water earlier does shorten labor more than waiting. But what they don't tell you is that you had that 40% chance of C-section on both sides of the study. And the reason why they really want to break your water is to shorten labor. Just keep in mind, though, that you're more likely to get epidural because it's much more painful to manage your contractions without that cushion from the bag of waters. The bag of waters also helps the baby rotate easier. Usually when your waters break naturally, it's a hind length, so it's a little bit higher up in your uterus. It's not like your floodgates open up like when they break the water at your cervix, which removes all of that fluid around the baby's head and shoulders that helps them to rotate and get in a good position. And just the way that like God designed birth, the bag of waters helps to have a general fluid pressure so that the contraction and the pressure of it is evenly distributed. The cord is nice and floaty. So you also get, I've been at births where they break the water and the next thing you know, the baby's heart rate just keeps dropping because now the cord is kind of slipped down and it's not staying floating in a safe position. So, and again, I'm not really trying to go through a whole birth class here, but there's a whole lot of things I can talk about. That's kind of one of my soapboxes is the AROM and not letting them break your waters prematurely. The next thing is no Pitocin to augment labor. So it's very common, like as a first-time mom, you might get to the hospital too soon and they're wanting to start Pitocin to get your labor going. You can always just ask to go home, but you can always stand your ground and say, look, I don't want to speed up my labor. It's very normal that contractions space out during the day. We don't really hear a lot about melatonin. I think oxytocin gets all the attention, but melatonin explains why so many mamas go into labor at night, why you have stronger contractions at night, because that melatonin hormone makes the oxytocin like twice as receptive. So it makes your contractions stronger. So it's very normal to have contractions. Let's say like they come out at 3 a.m. and you're heading to the hospital, and then during the day they kind of space out, and your nurse is saying things like, well, your labor is kind of gone away, so we need to start Pitocin, and you can always just either leave and come back or tell them that you really don't want to augment your labor, and again, most likely it'll come back stronger that evening. So that's really stage one. There's not a whole lot of other interventions that they're going to be wanting to do while you're laboring. You can have other things, of course, plan to how you're going to manage your pain, like what kind of movements you want to do. But I feel like for your birth plan, you just need to be very particular just about the interventions that are very common to come your way. So going into stage two, so this is the pushing phase. Now the pushing phase obviously doesn't start until either you spontaneously start pushing or someone's trying to tell you when to push. So the number one point you want to make is that you really want to have spontaneous pushing and you plan to labor down as long as possible. So your nurse and the doctors, they will know what labor down means, like because it's a topic of research of whether or not to start pushing just because you're 10 centimeters. Thankfully, they came out with a really big study last year. So this is new, where they did 10,000 moms. Actually, I have it here where we can look at it. So this is really important information to remember. So they did what was called delayed pushing. So just because you're 10 centimeters, they're allowing the mom up to 3 hours before she starts pushing. What they found was the average time of pushing was only 8 minutes. And that ranged from anywhere from 0 to 64 minutes. So definitely under an hour of pushing. Moms who had given birth previously pushed on an average of 5 minutes, whereas first time moms averaged about 14 minutes. Now that's huge information, because how many births have I attended where moms are pushing for 4 hours, and basically that's the cap. Usually they tell you once you push for 4 hours, it's like failure to progress, and you're just told to have a C-section, that your baby's just not going to be born vaginally. But all that can be avoided by just not starting. As soon as you start those practice pushes, you're on the clock for pushing, and they basically, like I said, tell you around that 4 hour mark that you've been pushing too long and we need to move into C-section. So always be prepared that you're not going to start pushing. Now this really is a problem, obviously, with epidural, because you're waiting on them to tell you what your dilation is and when to start pushing. So a good gauge is to say +2 station. So that's where the baby's at in the pelvis. You do not want to push your baby at 0 station, even +1, even +2, even with epidural. If you're not feeling any kind of pressure, it's always safer to just keep waiting. Ultimately, baby's going to start showing signs of like little dips where their head is being squeezed, they're starting to crown, and then that's where you'll have naturally spontaneous pushing. And this is going to have just such a huge benefit to you and the baby, not to be pushing for hours, and have that reduced oxygen to the baby, the increased tearing, and so on. So the next point I have is to deliver in an upright position. You want to be off of your sacrum. I do have an image that I want everyone's brains to be burned in their mind, of this bulging sacrum that we don't get to see, obviously, when moms are giving birth on their backs. Midwives would traditionally call this the opening of the back. So you don't want any pressure in the sacral area. You need to, even if you have epidural, try and push either sideline or be supported in an upright position. Next is on there, no coach pushing. So coach pushing sounds nice, but this is where they are telling you to hold your breath for 10 seconds, and push as hard as you can, push, push, push. You need to have it established that you will breathe as needed. You'll breathe instinctively. I definitely recommend doing like research on how like breathing is with spontaneous labor, slowing down your breathing during crowning, which I have in here. But be prepared for not holding your breath for 10 seconds. I mean, now there's also new studies that have come out that do prove that open glottis, so that's not holding your breath during pushing, has improved outcomes for mom and the baby. So just enough evidence to support no coach pushing. The next point is minimal perineal massage. So some doctors can be very handsy. Thankfully, if you're not on your back, they kind of don't know how to do perineal massage too well, because if you're on your back, they're just swiping up and down, of course, with gravity to stretch your perineum. More of a hands-off approach has been proven to be what's best. And if you use the word minimal, you're just putting out a signal like, hey, please do your bare minimum for me. Obviously, at their judgment, if they feel that some perineal massage is beneficial, they can make that judgment. But this is just to give them a heads up that you don't want the whole perineal massage. And I've seen it cause swelling in a couple of my clients where we're pushing, for too long, 3 hours, 4 hours. And now they're being told, hey, you need a C-section just because your perineum is so swollen. You're going to have too bad of a tear. And I'm thinking, well, maybe think it has anything to do with you with your gloved hands, just sitting there and doing such aggressive perineal massage for so long. Warm compress and oil is proven to, lubricate and help relax the tissues as you're pushing. So that's definitely something you can request. For some reason, they seem to forget it. Not the oil so much, but it seems as a doula, I'm kind of always having to remind them to get a warm compress prepared. Reminder to slow down crowning. So this also is something like usually your husband or your doula is having to do, because it's not something that's like standard in the hospital. They'll just keep telling you to bear down and hold your breath for 10 seconds, whether you're crowning or not. And this is how you can reduce a lot of tearing if you are told to basically stop pushing if baby's head is crowning. And again, if you were to hire a doula, she could teach you, like, or definitely do your research on how to breathe during that crowning phase. And you really want to push in between, baby crowning. Episiotomy. So most moms will just put in their birth plan, like no episiotomy or no vacuum. And that doesn't really benefit you because thankfully, even just from 10 years ago, like my first baby, I did have an episiotomy. But of the 100 births, I've not seen an episiotomy. I was at one birth where we did come close. The baby's head was halfway and it was just not emerging. And so we had to call the OB, attending OB had to come in. He had scissors in hand. And then all of a sudden I had this thought, like, maybe we can just change her position really quick. And so I asked really quickly, like, hey, can we just change her position really quickly? And he gave me dead eye contact and he said really quickly. And so me and her husband helped shift her hips. She had epidural. And as soon as we shifted her hips, the baby's head emerged, thankfully, and she was able to avoid episiotomy. So sometimes just having no episiotomy in your birth plan doesn't really help you because it's really used as an emergency. But if you can try and change position, that can be something to hopefully resolve baby's head stuck before going into that procedure. And then lastly, for stage 2, you definitely want to have a conversation with whoever's delivering your baby about a slow, gentle delivery of shoulders. So you want to allow for natural restitution of the baby. So natural birth, baby. Sorry, I'm showing you this picture here. So natural birth, after the baby's head is emerged, we have restitution where the baby naturally turns and then the baby's shoulders are born. So this is really not allowed in the hospital setting. You really have to have a conversation with your doctor and explain that you really want more of a natural approach to the baby's shoulders being delivered, because otherwise they're really going to just jerk your baby out within that one contraction. And this will help also reduce tearing. So you could be doing everything right up until this point. You could have done your breathing properly. You had warm compress. You're in the right position. You're slowing down during crowning. And then here the doctor is just pulling out the baby too fast and have your hands too involved during shoulder delivery and causes you to have a bad tear. So that's for stage 2. And if you wanted to have any input before we move to the next stage, Amanda, I know I'm kind of running through these topics.
No, I think this is great. And I love all of the extra tips that you're sharing about just, changing to a different position. That is amazing. I love that. And I love that you have a success story that it worked. That's great.
Yeah, definitely. Absolutely. So stage 3 is, after the baby's born. So this is everything that happens once baby is out. So obviously the first thing is that you do want immediate skin to skin. Some old school nurses can get a little bit, cleaning off the baby a little bit too fast, wiping off the vernix. Even I've seen nurses where they're like cleaning off the baby's hands, like by like each finger. And that amniotic fluid on the baby's hand actually assists in them finding, with their initial latch and helping to smell that colostrum. It smells very similar to amniotic fluid. So you really just want kind of hands off, have skin to skin. This is going to really benefit not just your bonding, but helping, your breast milk come in. And then also with the clamping down of your uterus. So just helping to initiate lots of oxytocin to help with your bleeding. The next thing that kind of happens in order is the delayed cord clamping. I really teach my clients to go ahead and just say, like, please give us 5 minutes. Even if you don't have like a time in there, they can definitely be rushing you. So it's like, here's the 1 minute mark. They're like, hey, you're ready to cut the cord. And the 2 minute marks are just bothering you every minute, trying to clamp the cord. So kind of having like a minimum time where you don't want to be bothered, and wait until it stops pulsating. And I will note that you need to do this at your own judgment. I've been at 3 births now where I kind of learned what happens if you don't have this preference in your plan, that the doctor will say, hey, we're going to check the cord and see if it's done pulsating. And I'm witnessing them squeezing the cord and milking the cord and kind of forcing it to stop pulsating, because they're just trying to rush that process. Wow. They do use cord blood for like they bank it and they use it for, like, for example, if there's pediatric surgeries and they need that baby's blood. Baby's blood is loaded with stem cells and twice as much oxygen and nutrients. And I learned this from one of my clients. Actually, she worked for clinical research, and she said, look, you'll be surprised that I know it gets into like conspiracy side of things, but she said they will line up certain moms inductions based on like your blood type, because they want that cord blood to be prepared for like a scheduled, pediatric surgery. So they really like to get that blood, but it's best for your baby to get the blood. It's loaded with iron, of course, and very beneficial to the start of life. It's what they need to transition to breathing. While they're learning to breathe, the circulation coming from the placenta is helping to keep their circulation strong and deliver all that oxygen rich blood as they're transitioning. The next thing is Pitocin. So every mama gets Pitocin. It's prophylactic, meaning it's preventative medicine where they're trying to help give your uterus that extra strength to clamp down and to reduce the bleeding. What I will tell you is that typically they give mamas, all mamas across the board, the maximum amount. So it's supposed to be, and I'll show you this, which I got from a book. It's so they're supposed to give you 10 units at a time. So they're supposed to give you 10 units of Pitocin if your bleeding's not good, and then only increase it by 10 units, not to exceed 40 units. And so far, the hospitals around me, they give every mama 40 units. They actually give them a bag of 20 units that runs really fast, and then they hook up a second bag of 20 units that runs slowly, more of a slow drip. And so if it's not necessary, the Pitocin can interrupt with your natural oxytocin hormones. When you're trying to have your breast milk come in and bond with your baby, it does increase afterbirth pains. So it's something that you just kind of want to have noted in your birth plan. Now, you will have the nurse or doctor say, well, if we don't get it started through the IV and your bleeding is bad, then it's kind of hard to get ahead of it. So having your birth plan that you are okay with an intramuscular injection will kind of help them to kind of back off on that, because they want to be able to give you the Pitocin a lot quicker, because otherwise it is diluted in IV fluids. And of course, they have other drugs to manage hemorrhage like TXA and rectal cytotec. The next point is for the placenta delivery. You do want time for your placenta to detach up to 30 minutes with minimal to no controlled cord traction. So if you don't have this in your birth plan, they will begin tugging on your placenta, like as soon as they clamp and cut the cord. They want to go ahead and get the placenta out. I've heard nurses repeat back to my clients that the placenta is delivered normally within 5 minutes, but this isn't true. Naturally, it is kind of around that 30-minute mark. Placenta is ready because it takes a certain amount of contractions. So after you give birth, you're still going to have contractions rolling in, especially if you initiate breastfeeding. You're going to get good, strong contractions that help the uterus to clamp down. So this is a risk of the strong traction on the umbilical cord. You can have uterine inversion where, the uterus prolapses. Even one of my own births I had where they caused my placenta to tear, and then they had to scrape the remaining pieces out. So this can all be avoided by just being patient and allowing time for your placenta to detach naturally without having controlled cord traction. The next point is the fundal massage. I know we hear about how painful that can be, so definitely let your nurse know. Your nurse is usually in charge of all the fundal rubs. That if your uterus is firm, the fundal massage is really unnecessary. The whole point of the fundal massage is to help stimulate your uterus. So if your uterus is what they call boggy, it's not toning up, if it's not firm and center, then they need to give a rub to help stimulate it and get it to, clamp down. So gentle fundal massage is what you want to ask for, and for them to please, not be so rough, because at that point they're just causing unnecessary bleeding. And then last of all is for tearing. If you're having small tears, they're not bleeding after pressure is applied, you really do heal naturally. Be aware that at some hospitals, especially if you're delivering with a resident, meaning that they're a newer doctor, that they do practice their stitching on small tears. So you really can have stitching that's kind of unnecessary. And I really believe you do heal better naturally than kind of being forced to heal a certain way for the small tears that are not, actively bleeding. And then have something in your birth plan for the first latch. So, you really want to plan to initiate that first latch by about the 30-minute mark. Ideally, if you can try and be skin to skin with your baby for at least 3 hours is where you see the most success with breastfeeding. I do recommend the Thompson method. for preparing for breastfeeding. So try and push off the weighing and measuring as long as you can, or at least have them do it pretty quickly so you can get back to skin with your baby. And then within those first 2 hours, you had the eye antibiotics. So make sure you have your decision on whether or not you want that given to your baby, and the vitamin K shot. And then hepatitis B, it just depends on the hospital. Sometimes they give it within 2 hours of the birth, or they do it like 24 hours later. So have it in your birth plan. Anything else related to baby, like for newborn screenings or like being in the room with you, that kind of is not applicable to your birth plan, because this is just for what goes on in the labor and delivery room. So you could have a separate plan to give your postpartum nurse once you get wheeled over to the postpartum side. So again, I know I ran through this pretty quickly, but just wanted to give the listeners sort of a basic birth plan of the things that they are really important to include, um, and to have these conversations ahead of time, even with your provider, and to make sure, like I said, when you're in at your birth, not to rely on your nurse to relay this information, to ask to speak with whoever's on the floor that day, whoever's going to be delivering your baby, to have this conversation with them before you get into pushing, before they show up. So yeah, that that was a quick run through. That's what I had prepared for today, and I hope it's a blessing to everyone.
Absolutely. Thank you so very much. I wish I would have had all of this information prior.
Yeah, me
It could have
too.
changed. I mean, and I read so many books before, my first baby, and still just having it broken down just very simply like this would have been so helpful before, because you get lost in all of the information.
You
And so
do, yeah,
having this just broken down so simply was so helpful. Thank you so very much, Rebecca. I really
absolutely,
appreciate this. So
absolutely.
where can people find you?
Yeah, so we'll have linked my website, and then I do have a Telegram group that I would love for you to join. It's just a great platform where I have resources organized in different folders for just helping give you, childbirth education and how to prepare for natural birth. And so we'll have that linked in the description as well.
Fantastic. Thank you so much again, Miss Rebecca. I really appreciate you coming on and going over this, what can be a really overwhelming topic to conquer, and, filling out our birth plans and getting all this together. So I really appreciate you coming on and taking the time to provide this really helpful information, and also the birth plan. So thank you very much. This is very, very kind of you. Thank you.
Yeah, you're welcome. My pleasure.
All right, everyone. Thank you so much for tuning in to the Coffee and Grace podcast with Amanda, and we'll see you again on a future podcast. Take care now.